Good morning, and welcome to this meeting of the Primary Care Task Force, the Data and Research Workgroup. This is the second meeting of this Data and Research Workgroup. First of all, just want to thank all of the members of this workgroup for taking the time to continue to participate in this important work of the task force, and in particular, the important work that we have before us today in continuing the conversations around data, measurement, and reporting, important factors for the entire task force work. Um, I am really, really energized and enthused about the progress that we've been making as this full task force has been moving along this calendar year. This is actually our fifth meeting of either a work group or the full task force, and we have a few more scheduled for later this month. So we are definitely moving at a pace, and I'm excited to be able to bring to you today a conversation around our first deliverable, which the deadline for which, according to our statutory mandate, is coming up soon. But before we dive into the agenda for today and the minutes, first let me turn it over to the co-chair of the Primary Care Task Force, Dr. Mahania, just to provide a few welcoming remarks.
Thank you, everyone. And thank you, David and HBC team for shouldering this work. I think mostly I just wanted to emphasize that these are very difficult times. These are very trying times. And what we come up with out of this work group is really going to be one of the foundational stones that the legislature will be using in terms of what we are hoping to be significant primary care reform. So please keep your thinking hats on and please try to follow David's lead as we are moving ahead really fast, but we want to make sure that we hear your voices and your expert opinions.
Thank you. Before we dive in, we do have a bit of business to take care of, which is approval of the minutes from our last meeting. And because we are doing this meeting virtually, we are going to have to do a roll call vote. And so I'll call each of your names and you can respond with a yay or a nay. But first, I just wanted to ask if there are any comments, questions, modifications that anyone had to the minutes that were circulated. Seeing none, I'm happy to entertain a motion.
So moved.
So moved.
Thank you. And a second motion, please.
Second.
Thank you both. All right. And if you just move to the next slide, you can see the vote here. And I'll just be calling your names in order here. So first, Dr. Mahania.
Aye.
I also vote aye. Senator Friedman.
I think I abstain. I think I missed the first one.
Great. Thank you. The commissioner is not with us today, so moving on to Lauren Peters.
Aye.
Dr. Schwarz.
Aye.
Suzanne Curry.
Aye.
Dr. Friedberg.
Aye.
Dr. Mellon.
Aye.
Laura Pellegrini.
Aye.
And Barbara Repson.
Aye.
Great. Thank you. The motion passes and the minutes are approved. So our goal today is really to focus our conversation and discussion on these first two deliverables. This is the list of all 7 of the deliverables that are included in our statutory mandate. And we're going to focus on these first 2 today: defining primary care services and codes for the purposes of measuring spending, and then developing a standardized set of data and reporting requirements. The first part of our conversation, we're going to focus on deliverable 1. And today we have kind of a draft, some may call it a straw man proposal for what this deliverable might look like for your discussion and input today. We don't plan to make a final decision on that deliverable today, but we want to be able to have time for your thought and input as we plan to then bring a draft deliverable to the full task force for their consideration later this month. So if we move on to the next slide. So as I said, we've developed a draft proposal for discussion today, and really we in developing this, we went back and we really reviewed the conversation that we had as a work group, and the presentation from Chia in particular, as well as the conversation that we had at the full task force meeting to create this outline of what a deliverable might look like for this first statutory mandate. And we circulated it around late afternoon yesterday, but I'll walk through kind of the outline of what we're proposing here, and then really just open it up for a conversation about whether we think that this is the right direction and makes sense. So as you can see on this slide, we put together kind of a brief outline of what the deliverable might look like. First, we start with just a brief introduction to the issue. Then we go into what the policy recommendation would include, which has 6 subcomponent parts. One talking about a designated agency, a transparent methodology, public input, annual reporting, and how this relates to a spending target measurement. And then finally, the process would include a summary of the current Chia methodology and annual update process. And not included on this slide, the final section would be a section of additional policy considerations, areas where this task force had discussed questions that may require further exploration or further consideration in the future. And we wanted to be able to document those areas of continued kind of question and consideration. And so that would be the proposed last section of this overall deliverable. I'm going to walk through the first 2 parts of this really briefly, and then stop and have some conversation. So first, on the next slide, that we have an introduction part to this deliverable, and the introduction is really just about describing the importance of measuring primary care, highlighting its values and the challenges that it's facing, including the reduced growth in primary care investment compared to all other medical services. The highlight of this introduction is really just to emphasize the important role of measuring primary care spending data to support policy data changes, investments and reforms, as well as for setting improvement targets. And we really appreciated the fact that we, as a state, have an agency that is currently doing this. And we got to hear an extensive conversation at the last meeting about how Chia currently measures primary care spending, and how it does generally align with the approach of many other states that are do primary care measurement. Although reflecting, of course, that there is still no national consensus or standard that kind of everyone has agreed to. Chia's process was developed and through it and informed by a public input process. And so this introduction really is just around highlighting the importance of measurements and why this deliverable is important. And then we would move into the heart of the recommendation on the next slide. And here, as I said, our recommendation for your consideration today is to recommend that Chia be the designated agency to continue this work of measuring primary care spending, that we have a highly credible and robust process already, and that we should continue with Chia's foundation as the state moves forward with other policies and strategies to increase investment in primary care. And so on the next slide, there are 6 subcomponent pieces to this recommendation. The first, it would be designating in statute that Chia is the agency responsible for defining, measuring, and reporting on primary care, and that they would have the authority to collect such information as is necessary to do this, play this role. Another consideration here could have been that we designate a different state agency to do this work, or that we designate an entirely new body to do this work. Our draft recommendation here is that we have a credible agency that is already doing this work, and that the legislature should codify CHIA's role in doing this. The second subcomponent piece gets to broadly describe the methodology that we would recommend that CHIA pursue, and that methodology should be public, and that the data specifications should be available for all different parties to be able to review, and that it would include a designated list of primary care services and codes of provider types and the reporting requirements for non-claims payments. Here we also say that CHIA should be informed by the methodologies used in other states, but we don't tie our methodology to one other state. That could have been an option here as well. So, really our recommendation here is not to define in statute the list of primary care services, codes, and provider types, but to defer that work to CHIA. This was a source of conversation at our last work group meeting, and Dr. Friedberg, you shared with us a report that had been done, I think, out of the University of Colorado that talked about how states have approached primary care spending measurement, and a recommendation that that you don't put into statute all of the codes and lists of provider types, that would allow for flexibility and the evolution that may appropriately come over time. As I said, we're also not necessarily recommending that we fully adopt a methodology used in another state, although we do want to be aligned with those other states. And this just gives us the flexibility to make sure that we're making these decisions based on Massachusetts data and market. The third subcomponent piece here is a requirement that there should be a process for soliciting and considering input on the methodology, and that CHIA should be intentional about seeking the input of primary care providers, behavioral health providers, health systems, health plans, essentially the makeup of this primary care task force, and that we would ask CHIA to, as part of an annual process for considering updates to its methodology, proactively seek out that input. And then finally, that other state agencies such as Mass Health and DPH and HPC would also be consulted on any changes to the methodology. Next slide. Finally, two other subcomponent pieces to this recommendation. One is that CHIA should be reporting annually on the primary care spending in Massachusetts across a number of different variables, including as a share of total statewide expenditures, by member, by insurance type, by age groups, by payer, and managing physician organization. The recommendation would also direct the HPC in its annual cost trends report to also provide analysis of trends in primary care spending, and that we may conduct complementary analyses based on the all payer claims database. And then the final subcomponent piece to this recommendation would be that we signal that the annual reporting done by CHIA here should be used for the purposes of setting a primary care target. That is a separate deliverable for this task force. It's actually deliverable number 3. So in this recommendation, we're not saying what the spending target should be or exactly how that should be measured. But nonetheless, I think in this deliverable, we want to indicate that however we ultimately decide to set a spending target, that it should be based on this CHIA foundation of measurement and reporting. I've included a sub-bullet here that reflects a little bit of the conversation that we had about perhaps for the purposes of setting a primary care spending target, we may want to treat pharmaceutical spending in a different way in terms of including in the denominator. I've included that consideration here, but ultimately I think we'll have to wrestle with that question a little bit more when we get to setting the spending target and how exactly we want to calculate it. So I'm going to pause here and maybe just ask that we go back one slide, and so you can see the first 3 parts of this recommendation. And really, at this point, just want to open it up and just kind of ask the broad question. Does this seem like the right direction we should be going in? Is this the right level of consideration in terms of details and deference and flexibility? Um, so we'll open it up, and Dr. Altman, I saw your hand go up first.
Okay, thank you, David. I actually am a huge fan of everything that you've presented and strongly support what you've just presented being brought back to the task force writ large. The one thing I would add, and forgive me if I missed it and it was already there, the one tiny thing I would add to this is that the primary care task force, I think it should be in statute that the primary care task force be asked to advise CHIA on this definition moving forward. That's all.
Thank you, Dr. Altman. I had included language in here, kind of broadly around CHIA seeking the input of, essentially the makeup of the task force. I think there is a question that I think the full task force will need to consider is, should there be, kind of an ongoing role for the primary care task force even beyond this work of doing these deliverables? And I hear your point that you think there should be, and that we should be explicit about that. Thank you.
Exactly.
Dr. Freeberg.
Similar comment to Dr. Altman's comment, actually. So I think the contours here are really great. I like the idea of some kind of standing advisory body as part of the public input and generation of transparent methodology. I don't know if the primary care task force, as currently constituted, is optimally composed to give highly technical advice on something that's ultimately like a very weedy methodological area. It may be good to model it after. I was thinking actually a great model for this is the way the quality measure advisement task force, or alignment task force rather, has advised the EOHHS on the aligned measure set. That has a flexible membership as determined by EOHHS through a procurement process that really has worked well and is a great model for that kind of a technical advisory group for the state.
Thank you, Dr. Freeberg. And I like that idea of perhaps being even more explicit and not just saying that the CHIA should, kind of seek the input, but that there would be, a standing body that would help advise. Suzanne Curry?
Thanks. I just want to echo the past two comments. I was going to ask Ashley about the role of this task, the broader primary care task force in thinking about the public input piece. So I think Wayne, Dr. Altman has really talked about that. The other piece I just wanted to ask about was there, and I don't think we necessarily need to go into detail about this if it's for recommendations to the legislature, but if there was any thinking about the changing the public input process from what it is today as how CHIA does it, both in terms of, I think a lot of these folks can comment on the methodology, but also kind of the time frame and things like that. I was just curious as to whether when you guys were putting this together, you were thinking about any changes that you would want to put into place to the current process.
Yeah, I think that's a great question. I certainly think that even in legislation, we can think about again who has that input into this process. Is that the primary care task force? Is it some type of technical advisory group? I think at a minimum, what I had included here was that CHIA should be proactive about seeking input, but I think there's different ways we could structure that as you suggest. I think I won't put Lauren on the spot, but I think, I'm pretty certain CHIA would be open to ideas about if there are ways to, better time or think about that public input process so that we're actually, really engaging people in these decisions. I don't know, Lauren, if you have anything to say.
And I don't have any ideas right now. I was just curious as to whether that was something there was something else behind that as well. So thank you.
I
I think it's an important piece.
Yeah, I absolutely agree that I think we put it here as a kind of a sub part of the recommendation on purpose that we wanted to highlight that this is important, right? And so I think we could think about if there's more detail that's needed. Lauren, did you want to ch chime in with
Sure.
anything?
I mean, I was really just going to say, like, we are, um, you know, we're excited about the opportunity to potentially expand the set of stakeholders that we're getting input from, whether that's in the form of an advisory council or just through proactive outreach to a broader set of stakeholders than the group that we're currently sort of seeking input on for methodological changes right now. So we're very much open. We welcome suggestions from this group in terms of what is the best way to capture sort of a broad range of feedback on our methodology, and can sort of confirm that the timing that the schedule and sequencing that we use now still makes sense going forward.
Thanks,
Thank you.
Lauren. Senator Friedman.
Yeah, I just want to talk a little bit about the legislative intent since I'm intimately
Please.
involved with it. So the intent of this is to make this a permanent working group. And the temporariness of it was was around the fact that we had such a short amount of time to move this bill forward. And okay, so the primary care task force, I mean, the primary care bill currently has a standing committee in it, which is this committee. I would argue that whatever we decide the makeup of this committee is the committee that should be giving the input. Public input, the word public makes me shudder, not because I don't love the public, but you know, we need to have people who really understand or have some direct control over this kind of issue to be weighing in. And I really think that we want to limit the amount of agencies, inputs, commissions that go into this. So I would argue that given the intent of this, that the input comes from the primary care task force. And if we need to fix the primary care task force to add, to change the makeup so that we are capable of doing this, I would argue that that's what we should focus on. Because that is the intent of this, and it's modeled after other states that have these primary care boards, and they're responsible for this. And if they need to go talk to somebody, they need to go talk to ASIP or they need to go talk to somebody, they need to do that. That should be their job. So that's how we envisioned it. And I would just let's keep it as streamlined as possible.
That's great. Thank you for that insight. I think we could be explicit in this deliverable around the input coming from the primary care advisory group or whatever we want to call that. And and hear you, Senator. We put public input here, but really it's around expert input as well, and the technical expertise that we want to make sure that we're tapping into. So I think we could work on that language a little bit, but I'm with you. Barbara?
Yeah, thank you. And thanks, Senator Friedman. That's really helpful to think about. So I also, think this is this is a great proposal. And support building on the work that we've already done in the state. So that's terrific. I do have a question, though, about these additional policy considerations. So it says in developing this, we did have some robust discussions about the idea of, Medicare data, OBGYN, use cases for different uses of this. At what point in the process does that get discussed, or how does that become part of this or not in terms of the recommendations?
Yeah, so that's an additional piece, and I want to get to that and have a further conversation around those additional considerations. I think what I was envisioning here is that would be part of the package, that all of this is part of the deliverable that we're handing over to the legislature, that it includes the introduction, it includes this explicit recommendation, It includes, a description of the current CHIA process, and then finally a section that talks about these additional policy considerations. I think the thinking here is that these are areas that merit future, additional consideration, additional work, additional exploration that may just be, you know, we want to make sure that we're documenting that and the task force is saying, hey, these are areas that we think probably need a little bit more thinking. And so that was the thinking of including it, yes, in this deliverable, but not necessarily that this task force is going to be in a position to decide exactly how to do like original Medicare. Like that's something that CHIA probably needs to work on with CMS. So when we get to that section, Barbara, I'd be interested if you think that there are some areas where we should be more explicit in making decisions now versus, really identifying areas for future thought. Dr. Friedberg. You're on mute, sorry.
Was inferring from this that the pace of updating the methodology would be annual. Of course, it wouldn't have to be updated every year, but it could be. As I would just recommend making that explicit if that's the case. I think that makes sense. That's the usual pace of, with which like new codes are, released.
Yep, absolutely can make that explicit. That was the intent. Dr. Mellon.
Thank you. And thank you for sharing the background as to how this was developed. Very interesting. Just, I think the comment that I'm about to make would best be considered a placeholder comment as well as a question. As Barbara Rabson just mentioned, Medicare data availability. I'm a proponent of finding a way to include that or to recognize the absence of it, maybe make a proxy, a lot of options, but just keeping that in mind, right? Because there's a distinct imbalance between the Medicare proportion of reimbursement or care by a geriatrician as compared with a neonatologist, for example. I also am interested in whether, in a situation like this, I'm glad to see that annual reporting is specified as to the level of the organization that would be reported on. I wonder whether it's ever helpful to indicate that it wouldn't drill down, at least for the public to see, to the individual provider level, for example. I can envision a patient who feels that a lot of testing is always good for them, looking for the most highly reimbursed individual who's a provider and moving quickly to try to get into that physician's practice. And that would be an unintended consequence, certainly not necessarily beneficial to the patient at all, but we should be mindful of that, as well as the fact that we're talking about here the managing physician organization level for reporting rather than drilling down below that by payer, rather than drilling down into each individual product by the payer. Those are, in my opinion, better ways for us to consider reporting for public purposes. I'm also glad to see by age group, I remember Dr. Friedberg had brought that up at a previous meeting. And finally, a placeholder around whether we are employing risk adjustment in this at all. And that is more, in addition to age group, that is more a consideration when we get to deliverable 3, I realize, but it might be worthwhile to include it by mention in this report so that when we get to that deliverable 3, we can remember that we thought about it. Thank you.
Those are great comments. Thank you so much. And I think it's probably worthwhile at this point to move to that section around kind of the additional policy considerations that we included. And really there, the goal was exactly what you just said, to reflect those areas where this group has discussed that there are some limitations with this current process, and that we want to be able to document those and be able to say, hey, like it would really be great if we can continue to work on these and maybe find either proxy solutions or other ways of being able to recognize that. And to the point of some of the public reporting, you know, it's being explicit that it is at that kind of a little bit of a higher level. That is the way that Chia is currently reporting it out. And so I think, you know, that makes sense to be clear about that.
I'm going to thank you. If I could interrupt just
Yeah,
for a moment,
please.
I'm going to add one more consideration, and that is that at an earlier meeting, you and others, I believe, talked about the importance of not changing, right, the measurement methodology all the time, because how do we know how we're doing? And I certainly recognize that. I also recognize that, you know, maybe we'll find a way, I'm going to say Medicare again, right? Maybe we'll find a way, for example, to be able to report around Medicare. And so it may be that including mention of modification of the reporting methodology when warranted could be useful here. Thank you.
Yep. Senator?
I just wanted to reiterate what you said, David, to Dr. Mellon. Everything we do is aggregated. We do not, there's nothing in language that we would allow for a report to be specific, you know, in terms of what we're doing here, which is how to define primary care and what we should be paying for it. So just want that to be clear. And it's everywhere in every statute we write. So, but the other thing, I think we're going to move into kind of discussion of data. And I just want to be really, really sensitive to be talking about data that we really, really need, not that we would, you know, we could ask for thousands of, you know, cells of data. And I just want us to be cognizant of A, what do we really need? Like we've got so much data that we collect, and I would argue probably in any given time, much of that data is no longer relevant. And so I really want us to focus on that. And I also want to want us all to remember that a human being at the end of the day is going to be looking at this data and gathering this data and creating code to collect this data. And we're going to require people to give us this data. And so I just really want to impress on everyone that we should only be getting what really, really matters to us so that we're not adding the burden to the already burdened system. So, and we didn't specifically put things into statutes so that there wouldn't be, you know, data that's no longer relevant in the middle of a statute. So I just am asking people, given what I know all the providers and Chia goes through and HBC, et cetera, et cetera. So thanks.
Thank you, Senator. I think you preempted a little bit of the preamble that I was going to give to the reporting requirements, and I'll do it a little bit again.
Sorry about that.
Oh no, it's perfect. All right, let's move through the rest of this deliverable. So, you know, we've walked through the pieces of the recommendation. I think as part of this deliverable, and again, just kind of reflecting the conversations we've had, we would include a section that just is a summary of the current CHIA methodology and annual process. So I won't walk through these. These are well known to you and from CHIA. So we can move through these two slides here. Again, this is just a documentation of the current process, understanding that there, as we're suggesting in the recommendation, that there could be some, you know, changes to this. And then the final section that I do want to spend a little bit of time just gathering input on is this kind of this section at the end of the deliverable, which would highlight these areas of, further exploration to seek to address in the future. Understanding that there are data limitations to some of these. There are conceptual limitations about what we can ask of providers to even get at these levels, but really wanted to have a section of the deliverable that reflected those areas of inquiry and and limitations, as I said. So I won't read through all of these, but happy to pause here for a moment to see if there are additional kind of topics or areas that we, discussed as a work group that at a minimum you feel should be, kind of captured in our final deliverable. I'll note one here uh, that again, I don't know that we have a ready set solution for, but is thinking about those direct primary care arrangements where patients are paying directly to the primary care and it's not running necessarily through the insurance system. I think that is an area we need to continue to think about, but I don't know that we had a, a ready-made solution for that. So Suzanne. You're on mute. Sorry, Suzanne, you're on mute.
Oh my gosh, sorry. That's embarrassing to go know that by now. Thank you. I was thinking about the second, third, and fourth bullet and thinking about I'm not sure how to square this with the actual data around the spending piece, but I do remember talking about the non-claims data piece and maybe, services that are provided by other professionals on the team, care coordination, community health workers, things like that, and the integrated behavioral health piece. And I think that those considerations are all important to think about when we're thinking about not only measuring primary care spending, but maybe moving into the place where we're looking at what do we want primary care to look like, and then how do we create the spending target that can accommodate all those things for a team-based approach. So I think those considerations, I think the second, third, and fourth bullet are really important there. So just wanted to thank you for including those.
Thank you. Dr. Friedberg.
One other dimension to consider here, I think there's an appropriate focus on kind of which categories of providers are considered to be primary care, but you could also, I would just flag the range of services is also important to include. Some definitions that very narrowly define primary care kind of won't capture services provided by primary care providers who are a little more comprehensive in what they offer, like doing laceration repairs and destruction of skin lesions and things like that in the office, which is kind of something we may want to encourage in the spirit of comprehensiveness.
Thank you, Mark. I think we could have a consideration that's kind of, that same tenor like that we have for the third one here around other professionals and thinking about the services in the primary care setting as well. Barbara?
Yeah, thank you. So one of the things that I'm not sure it should go into primary care spend, but I think this group should talk about it, is that because there's such a shortage of primary care, people are going to alternative services, including urgent care. And nothing here is captured, none of the urgent care, independent places where people often go for care are captured in this. And so I'm not suggesting that that should be part of primary care spend, but we should be aware that there's people getting primary care in places that we're not accounting for. And so if we want a more complete picture, how do we want to track that? And I think the fact that everything Chia does is modular, from my understanding, would allow that kind of, okay, build this model and then we can look at that. But I think that it is important to acknowledge that a lot of people, because of the shortage of primary care, people are getting it elsewhere and as in urgent care, and that's actually growing.
Thank you, Barbara. And I think part of my thinking, at least in this particular section, was that there may be places where we're not necessarily going to be able to add it into primary care spending, nor maybe it would be appropriate to add into primary care spending as we're measuring it, but that there may be areas of that we want to have complementary insight into. And so that was, some of the spirit of what I was trying to document, or we were trying to document in this particular section. So I take your point. Dr. Altman.
Yeah, just really quickly, I agree with Barbara that this is definitely a growing area. I would also say that primary care is continuity and urgent care is not primary care, and that it doesn't make sense for that to be in the numerator. So thank you.
Yep, I agree.
Yeah, I
Dr.
agree
Mellon?
with that too. I'm not, but I think acknowledging that that is where people are getting care as we're looking at this is important in some way, shape, or form.
Dr. Mellon.
I'm wondering whether, as a corollary to point 5, we want to include mention of uncompensated care, I'll call it, not by the traditional definition, but uncompensated care that physicians, often primary care physicians, give, even if they're not in a direct contract with an employer, et cetera. The pillow time, the pajama time, all of the form filling out and such, only a very small portion of which is billable and then therefore potentially recognized in CHIA's database. So we might broaden that 5th item, not to focus only on individuals in direct contracts or concierge care, but on all of us, including those individuals.
Thank you, Dr. Mellon. I really appreciate that comment. I think um, we tried to capture a little bit of that in number 2, where we're talking about services that are delivered but not billed. But I think you're talking beyond services and talking about maybe activities.
Yes,
Is that fair?
I think that's very fair. Yes, thank you.
Senator.
I'm just a little confused though. What we're talking about here is how are we looking about what primary care should mean and include, or are we talking about just measuring what we do right now? You see what I'm asking? Because like we don't want to measure, we want to measure the things that are primary care that happen in an urgent care center, like a strep throat, but we don't want to measure who's going to urgent care, right? Or, right, but it sort of depends on what we're focusing on here. So I'm a little confused about, are we trying to get, just what else do we need CHIA to capture? Or how are we going to define primary care going forward? Do you see what my confusion is?
Yeah, I'll take a shot at that, and then I would love to hear from others. I think the conversation here around the urgent care was not to suggest that we consider that primary care spending, or for the purposes of what we're defining. So that would, I think, my recommendation is that not be included in primary care. I think what Barbara was really saying is we have to recognize that is where some people are getting care. And so just understanding the trend of like how often are people going for what types of services just may be informative if we're thinking about like we want to get people into the longitudinal primary care setting. And so I viewed Barbara's comment as more as like just understanding the universe, but keeping our focus on what is primary care and what we're trying to invest in and support. Does that help, Senator?
Yes, yeah. It's all kind of gets munged together, and I understand why that happens. I mean, because we're doing I think we're doing a couple things at the same time, which is fine. I think we need to do that, but um, uh, I'll sit with my bit of confusion and probably get cleared up as we move on. So Sorry about that.
No, thank you. And this is, this is an opportunity for us to gather that information so that we can have clarity in what we're actually saying in this section, and whether these are, um, explicitly areas that we think should be, included into the primary care spend versus kind of areas of adjacent investigation, so to speak. Um, so this was the final part of the deliverable, and so again, I'll just I feel like I've gotten some uh, positive feedback in terms of kind of the outline of what we've proposed here, and with some good feedback on some areas where we could perhaps provide some additional clarity and nuance. Dr. Mahania, I'm curious, any thoughts that you have?
No, I think all the questions that were raised were valid ones, including Cindy's sort of epistemologic question, which is, what are we establishing something that already exists, or are we aspirational? So I think those are all great discussions. So no, nothing intelligent to add, David.
So let me just ask the group, with some modifications to the text as we've discussed today, do the work group members feel comfortable bringing this proposal to the full task force for discussion?
Yes.
Great. Thank you. So we'll continue to work on this, and we'll be in touch. So that's wonderful. Let's move on to the second part of our conversation today. Well, I'll just wanted to just say quickly, reflecting the bills that are filed currently before the legislature. Um, all three of the bills do defer to CHIA in terms of setting the primary care measurement, um, as well as considering recommendations from the primary care task force, as Senator Friedman mentioned earlier. So our deliverable here and recommendation is well in line with the current thinking in the proposals before the legislature. Okay, let's move on. So, statutory deliverable number 2 is around developing a standardized set of data and reporting requirements for private and public payers, providers, and provider organizations. As the senator has said, we have a pretty extensive and robust infrastructure of data reporting from health plans, providers, and provider organizations as it exists today. I would suggest that Massachusetts um, is probably the leading state when it comes to the information that we collect from provider organizations and health plans. And so, as the senator said, as we think about, are there additional areas that require additional reporting? Um, I We would recommend, being judicious in thinking about what those are, and reflecting, of course, that part of this task force's charge is around trying to alleviate some of the administrative burden in our healthcare system that contributes to um, time away from clinical and patient care. But nonetheless, this was a deliverable here that we've been asked to weigh in on, and there has been some discussion, particularly, I would say, around bullet number 3, which is around, is there additional information needed around the use of the non-claims payments that go to provider organizations? There has been some discussion that right now the CHIA process does include non-claims payments if the health plan knows that they are going to primary care. And I'm looking to Caitlin to make sure I get this right. But that in often cases, the health plan may not know how those non-claims payments are actually distributed within a provider organization. I've listed out some other discussion questions here, but we'll really just, at this point, just kind of open it up. Are there particular focused areas that we do think are worth, kind of further investigation in terms of additional information that we're going to need as we think about the package of policies that we're working toward. Dr. Altman.
Thank you, David. I think this is something that's really important. At the end of the year, I am a co-owner of a private practice in Arlington. At the end of every year, we get a chunk of money from two different pots of money, and that can range pretty dramatically. And our physician organization, the way they divvy up that money, they have their own proprietary formula that accounts for hospitals and specialists and primary care and so on. And every organization has their own formula. So when the payers deliver money to primary care that was intended for primary care, the payers have no control over whether it actually gets to primary care and no knowledge either. And I would love it if it were possible to explicitly have statute that forces organizations to be transparent about what money is going to primary care, so that when there's primary care legislation and there are audits by the Health Policy Commission potentially to look at primary care funds flow, that black box is opened up. I'd love to hear what people think about that idea.
Mark, please chime in.
Yeah, I completely agree. And I would say that not only applies to the non claims-based payments, but also applies to claims-based payments themselves. There's no way to know in a large organization that includes anything other than primary care in there, subspecialists, hospitals, you name it, how those payments are actually distributed. It's completely invisible to the payers.
Senator, what was some of the intent here?
Well, therein lies the crux of the problem. That is it. How do you track the dollars, right? And what do you ask for? I absolutely, this is critical. And I would also add to that, it's not only what they pay out, it's also what they claw back. So, you can watch funds go to the primary care practice, and then, oh, by the way, here's your bill for, the lights, here's your bill for using electronic health records, here's your, you know what I mean? It's like, it's really tracking it all. And yeah, this is it. This is what we're all struggling with. Because if we knew how to do this, we could get to what we need to, we'd really get to understand how much we're paying for it and what's included. So absolutely think this is great, but I would just make sure that it's a full circle. It's what we pay and then what the providers are on the hook for doing. And that also means, what is the other part, I think non-claims is, what do we expect you to tell us? So how much of your time is being looked at coding or requirements of coding, or, all of the things that a system can impose on an entity within their control, right? And primary care is especially vulnerable to this.
Thank you, Senator. I had included a sub kind of discussion question here around this idea of kind of in-kind services and how the larger organization may retain. I said non-claims in this discussion question, but it could be claims payments as well, in terms of those, like the EHR, the billing services, things that the system may be doing kind of on behalf of the primary care, and how much of that revenue is being kind of held in any way within the larger organization, and is that transparent to the provider organizations? Ryan, I'll get to you in just one quick second, but Dr. Altman, I maybe just on this point of retention of revenue for kind of in-kind services provided, is that something that is typical?
I don't understand what you mean.
Maybe it's more in an employed primary care model where the larger organization is paying for the electronic health record, is um, hiring separately, billing support, but then somehow accounting that back to the primary care practice.
Well, our practice is a private practice. We're not owned by a hospital system, but we do pay the hospital for the use of their electronic health record, as would a hospital practice.
Yep.
Uh, and so that clawback that Mark was talking about is relevant, or that Senator Friedman was talking about. Um, what I was talking about is that there's surplus and quality money that the insurance companies will hold back, and depending on how you perform, you get some of that money at the end of the year. But that goes through the ACO or the physician organization, and they have formulas to determine how much of that money you get and how much of it goes to specialists in that organization and how much of it goes to the hospitals. And so I think we should have explicit language in statute that says that they have to report that to CHIA or the Health Policy Commission, or both, what they're doing.
Right,
Thank
excuse me, David, because
Yeah.
that's the stuff that, like, if we say, if you get extra money as a primary care practice for staying open an extra hour or 2 hours, or you have a community health worker, in Mass Health pays you more for that. I mean, there's tiers for it. And how much of that is actually, if you're part of a system, how much of that is going to the primary care practice who is actually doing that work? That's what you're, yeah, that's critical. Yeah. Okay. Thank you. Sorry, David. I just wanted to
Oh,
know.
no, please. Thank you. And Dr. Altman, I think your answer, I think, also just elicits in me, that there are very different ways that organizations are structured in terms of an IPA versus an employed, and how those decisions around funds flow are made, and who is making those decisions could be very different across different organizations. And so it just adds to the complexity. Ryan, please tell us how you've solved this in Mass Health.
All right, I'm going to put my hand down and go on mute again now, David. We have certainly not solved it. A few thoughts, though. One, to just address the third point on the slide in terms of non-claims payment. I would, and not to put Caitlin and team on the spot here, but I think we have learned failed forward, I believe, is the right answer in terms of trying to report non-claims based payments, and the difficulty with ourselves identifying actually what those are constituted, and then communicating that in a way that is meaningful and digestible to CHIA in a way that they can actually report on. And I would just say that I think every payer and every provider system is going to have a lot of uphill learning, that CHIA is very well positioned to be kind of a central source of, again, Caitlin, not to put you guys on the spot, but like ultimately TA and centralizing some of the lessons that you guys have learned, where we, I think our 2023 reporting was grossly inaccurate ultimately in terms of trying to effectively communicate what the subcap program had spent in terms of the capitation dollars as opposed to the claims based. So all that is to say, I think all of us are going to have a lot of learning as we try and engage in some of that reporting, and CHIA is very well positioned to help be a centralized source for that. In terms of the Senator Friedman's points, Mark's, Wayne's about dollars flowing to the practice, a few quick thoughts. One, Wayne, you're in a private practice. And that is one structure. There are many other structures. One of the other dynamics that we've seen, which is challenging to even think about what the quote unquote right answer is when you are a part of a health plan, an MCO or an ACO, and that ACO or MCO offers services that are centralized across a network of primary care practices, for example, care management programs that may offer direct services to the practice, but are actually staffed at the ACO or the plan level, how you think about who is paying for those services, what accounting is attributed to the practice versus the plan, and is it appropriate that some of those dollars may actually remain at, for example, the ACO level to staff a care manager who is ultimately half of an FTE for one practice and half an FTE for another practice. There's many similar examples that we have run into in terms of thinking about where dollars are ultimately flowing, and with the intention that dollars are flowing to the practice, even the question of what dollars get to the practice and what dollars should get to the practice is a pretty complicated one that different payers are also going to grapple with as they work with provider systems to identify where those dollars are going. I think the broader point here, though, is that, as I believe as Barbara mentioned, we do need transparency into where dollars are going within the provider system if we are going to be able to identify what scope of the overall total healthcare dollar is ultimately getting to a primary care practice. I think it is a sub-question that CHIA and whatever ongoing technical advisory group advises CHIA will need to think about as to how we think about those dollars relative to the target. Does a dollar that stays at an ACO to pay for care management services that are ultimately incorporated into a practice level, does that count as a dollar that is going to primary care? And the EHR example, I think, is another one. There are a lot of very in the weeds questions that we'll need to think about in terms of what counts, and payers and providers obviously have a very vested interest in what goes in the numerator and what goes in the denominator. But we haven't yet solved it, David. Sorry.
Yeah. Dr. Altman, reflections on that, and then Caitlin, I will ask you to just chime in a little bit about what the current practice is and how you've been thinking about that.
So 2 quick thoughts. I really love the point that Ryan raised about that care manager, about that EHR, and money that is being spent on primary care for primary care, but in an organizational, organized way. I think that level of detail is critical, but probably not something that we would need to put in legislation, something that would be on a primary care task force level to figure out those details, but they would need to be figured out. The other thing I'll say is, and this is response to David as well, private practice or not private practice, almost all of us are part of ACOs who are part of that kind of scenario. So that scenario that Ryan described for a hospital-owned practice is also true for our private practice. So that's true for almost all of us. There are a handful of docs who don't associate with an IPA for contracting, but that they're very few and far between.
Mm-hmm. Mm-hmm.
I'm happy to chime in just to comment on the CHIA experience of working with Ryan and his great team at Mass Health. I think a huge advantage there, of course, is that built into their contracts, they have visibility into the funds flow in these dollars in a way that other payers do not, either because it's not in their contracts or because there just isn't a mechanism for getting that information back. So maybe a question to this group is, would the recommendation be around sharing of that information from the provider organization to CHIA, or would it be the provider organization sharing that information to their payers through the contractual process, and then the payers sharing that information with CHIA? It's a mechanical question, but I think an important one about, are we looking for providers to make that information transparent, or do we want it to be sort of between the provider and the payer as part of their work together?
I think it's a great question, Caitlin. I'm curious if members have thoughts on that.
David, I would think the plans would want to know this, but CHIA would want to know it. So how it's reported, if it's reported both from the provider group and the health plan, it should be reported to CHIA, but I think the plans would want to know this.
Senator?
I think it has to come from the providers, and yes, it's real, but it has to seem to me it has to come from the providers, because the providers are on so many different levels. Like, you need to get this from, if you're part of the BI Lahey primary care, we want to know from BI Lahey, right? We want to know where what you're saying, So I think it has to come from the, I think the providers have to provide this information. Now, I would argue that for everything we add to the providers, we should take something off so that they don't have to, so that we're not adding to it. But I really do think I don't know how the payers know this, right? And so it's kind of up to the state to say, this is what you need to tell us. That's my feeling.
So, Mark, I want to get to you in just one second, but I'm going to ask on a staff member from HPC care of it all. So we have been asking provider organizations about their fund flow mechanisms through our registration of provider organizations. I think, Senator, that's kind of like the best place to think about this, because you're getting at kind of the highest level of these organizations, and they're many very differently structured organizations. Kara, can you just say a little bit about what we have asked for, what we have learned from that, and what we haven't learned from that?
Yes, happy to. Thank you. So we do ask in our registration of provider organizations program annually, we ask organizations that contract on behalf of providers whether or not they participate in contracts that allow them to earn a surplus payment and or potentially owe a deficit payment. We ask them which types of providers are eligible to earn surplus payments, and there are checkbox options. So it could be PCPs, specialists, hospitals, behavioral health, and other, I believe, are the answer options. And then we also separately ask the provider types that are eligible to have or responsible potentially to pay back deficits. Same checkbox. And so we can see when it is the same types of providers that can earn surplus and be responsible for deficits, and when there is a difference, which there sometimes is. We also ask a little bit about how the decision is made to distribute surplus payments. So whether it's sort of made entirely centrally, or whether there is some allocation of responsibility to subdivisions. So we see sometimes it's the central ACO, the central MSO makes that decision entirely through its singular formula, and it gets trickled down that way. Or sometimes an amount will trickle to different subdivisions, and they have some element of control over how the money is further allocated within smaller groups. We don't know exactly what the mechanism is. We just know whether it's sort of centralized entirely or not. And then I believe we have a question about withhold payments as well, and the cases in which an entity can earn back a withhold payment. So is it, we sort of have separate questions for if you're in a surplus position, does everybody get part of their withhold back? Or do only groups that meet performance metrics get their withhold back? And then the same question, if you're in a deficit position, can you still earn part of your withhold back if you meet performance metrics, or can nobody earn part of the withhold back? So they are pretty high level, they're structural questions, but we do collect that information from our largest provider organizations.
And those, as you said, are more qualitative rather than like asking for the specific dollar amounts, correct, Kara?
That's correct, yep.
So I think just to the question of to whom should we collect this information, there is a reporting structure in place where we're getting it from the provider organization side. Dr. Freeberg, please.
Yeah, I think I agree with the Senator. This has to start with the provider organization. Whether it's reported to the plans or to the state, I'm kind of agnostic to. For either one of us, it would be quite new at the level of detail we're looking for. I wanted to also suggest a different data source as a supplement to this, which is to get some information directly from the frontline PCPs themselves and their teams, and get their perspectives on this. This is, at the end of the day, what we want to see are signs that things are better in primary care. And if you don't sort of see that the job is more doable, access is improving, payment is, the actual take-home incomes for the practice as a unit and for the individuals involved are increasing in some way, then it's not really getting there no matter what you're seeing as far as fund flows from an organization.
Lauren, please.
So another area of consideration and sort of relates to that comment is how do we track providers if we want to also capture how are providers investing in primary care? I think we need to think about how we can quantify and collect data in a standardized way where providers are, say, creating new locations or expanding hours over the weekend. Like how can we capture that so that provider organizations are necessarily getting credit, but doing so in a standardized way? I don't have an answer at the moment, but I do think that when we think about measuring payer investments, that's clearly more straightforward. I think with providers, we should be thinking about the multiple ways that providers can invest and spend money on primary care. And so I just wanted to ensure that we're not losing sight of mechanisms like expanding hours, for example. So that's on the table for I guess ways that provider organizations are making that investment.
Yeah, thank you, Lauren. I think that's, ultimately we're kind of all talking around this concept of like we want more money into primary care. How do we make sure that it's going into primary care and that it's going to actually make a meaningful difference, right? Meaningful difference for the providers, meaningful difference for patients. And I wonder if some of that could be addressed by thinking about the payment methodologies that we're using. And if we move towards a more subcapitated model like Mass Health that has as part of its, payment methodology, like there's different tiers and, the different tiers are you get paid more if you have the certain staffing structure and are open on, late nights. And, if we can maybe use the payment methodology as part of our solution here. But it's a half-baked thought. Barbara.
Yeah, just to reiterate, this is really complicated and really important. And I think that it's worth investing some qualitative research of talking to folks in hospitals to get a really better understanding, knowing it happens differently. But before we try to create something that we think makes sense, let's talk to the people who understand how the money flows and get a really good sense about that. Because I think because it is so complicated and it's really important, we don't want to get it wrong.
Can I respond to that? Because I think you're absolutely right. We've been working on this issue for 6 years, and the system is not going to tell you how they disperse that money in a way that you would feel really comfortable that you knew the answer. And so I think, well, I completely, what you're saying is absolutely right. And it's a place you would want to go because that's where it's happening. We've never been successful at doing that. Now, we're more successful at looking at systems that we think work and see what's working in that way. So, when we were talking about the different types of, practice, and there's the MCO, ACO, and they're centralized, and, I thought of C3, right? Well, how does C3 do that? That's their model, right? They provide this. How does it work? It's pretty successful. What part of Mass Health capitated is really good and working, and where are the problems so that we can work around them, or finding a system that actually pays their primary care practices in a way that we think we want to model, because that's the whole private piece of it, right? But I think looking at those is a really important thing for us to do, because can you imagine asking MGB how they pay their primary care practices, right? I mean, it's like it's not going to happen in a way that I think we would want it to happen, right? Because there's a lot of stuff going on there, and we know that. So I think your point is incredibly important, and maybe what we should look at what we think might work and go that way. It might get us in a more direct path, but yeah, I mean, we shouldn't have to invent all this.
Thank you, Senator. And I do think that there is still an opportunity, and this was something that we've been thinking about for, one of the full task force means is learning a little bit more about what the innovations that Mass Health has put in place. I think there is a model that is worth really considering there, if that could be extended to commercial plans that um, may help alleviate some of our concerns that if we're setting spending targets for increased investment, how do we make sure that that money is actually going to primary care and in a way that's actually going to be transformative in the care that's being delivered? I think that's ultimately the goal here. And I would further reflect both Barbara and Senator. I think a question for this work group and this task force is um, how much do we want to try to figure this out versus um, perhaps, kind of delegating this task to uh, Chia with the input and consultation of a, kind of primary care advisory group, um, understanding that we want to keep this momentum going in terms of setting out a structure for change. So I raise that as a question we'll have to consider. Dr. Altman.
Well, I'd love to answer your question, David. I think that's the right approach. This is hard, this is complicated, but there are ways to do it. We just don't have those ways at this moment. But there are, as Senator Friedman and others said, there are models that we can look at and people that we can talk to where we can develop those ways. So I think phase one, our job here as the primary care task force, is to recommend conceptually that these two big buckets, quality and surplus, that those buckets be transparent, and that systems and IPAs and ACOs be required to report those numbers. I would suggest both to payers and to CHIA. And that we recommend that the primary care task force makes recommendations to CHIA on how to do that, but we don't have to solve that problem in this task force's iteration.
Thank you, Dr. Altman. Ryan?
I would generally agree with Wayne, but I would add to that I think our own experience working with CHIA has demonstrated this is going to be iterative for every payer and every provider system, and there's going to be a lot of learning that goes into this. And with that learning, CHIA will also be able to then convey those lessons into more detailed, nuanced, sophisticated metrics in subsequent years, which I think also underscores nothing in statute, but giving CHIA the ability to continue to evolve their measurement and their dashboards such that as we get better as payers or provider systems in reporting what is actually what matters and what is meaningful, that CHIA can update their reporting as well.
Yeah, I think that's an important point. Thank you, Ryan. And I can see a deliverable here that is um, directional and conceptual, but without needing to solve all of the details, and that there will be some iteration on that front. Um, we're we're about 5 minutes out from the end of the meeting, and so would love to just see if there are anyone who wants to share some additional thoughts on this topic or the first topic. This has been a really great conversation, and I think gives us as co-chairs a lot to be able to take back and work on and come back with uh, perhaps a straw man proposal to think about on this deliverable number two. But happy to open it up to additional thoughts. Okay. Well, Barbara?
Sorry.
Yes, please.
Looking at the last bullet about patient access to primary care, and this is something that Mark Freeberg has brought up a lot. The idea that many of the data that we have about primary care doctors don't take into account that so many Massachusetts physicians work one session a week and then have other full-time jobs. And so I think there, we're really undercounting. And I had a conversation yesterday with someone on the Board of Registration of Medicine about, sort of the challenges of tracking that. But I'm just wondering if this area of it feels like that, there's a blind spot in terms of, sort of that aspect of what we know about the supply of primary care. And in terms of patient access, we don't have good data on, how many people don't get access to primary care. And there's the CHIA MHIS survey that, sort of is alarmingly high in terms of, 40% of the people say they can't get access to when they need it. But I'm just wondering if this is the appropriate group to do a little brainstorming on what kind of other metrics we might want collected in this.
There is I think it's a great question, Barbara. I don't know that I have like a clear answer for you just on the hot seat here today, but I would just note that there is another deliverable of this task force, which is around monitoring and tracking the needs of
Oh,
residents
right.
of the Commonwealth, um, which is a deliverable we got a little bit more time on in terms of the staggered deadlines. So that may be something where that might be the right place for that conversation.
That makes sense. Sorry, I forgot about that.
No, I'm literally just thinking of this on the top of my head as well. Um, okay, well, we do have some upcoming meetings. Let's show our upcoming calendar here. So we are meeting as a full task force on July 22nd. Please note that we had originally planned to do that in person. We're going to do that virtually. So that will be a virtual meeting. And then for the full task force, we do hope to come back in person at the September meeting. We'll have that meeting here at the HPC offices. And that will be a meeting where we would hope to be able to advance our first deliverable as we have discussed today. We don't have currently a scheduled work group meeting of this data and research work group, but we'll be reaching out to schedule that right after this meeting and get that on everyone's books and continue these conversations. We also have a workforce work group meeting at the end of this month. So we'll be in touch as also always through Kelsey with additional information. And if you all have any additional thoughts or resources, of course, please reach out to Kelsey, who is helping to manage all of that. And so I am happy to close out today's meeting and just say thank you again for a tremendous conversation and getting into the details of all of this. And we'll keep moving. Thank you all. Have a great day.